Well, people here know that in the 90s, the transfusion system was under the oil immersion lens because of the scandal and well, really the tainted blood problems. But because of that tainted blood issue, the transfusion system was really under a lot of scrutiny. What that did is it has now generated enormous reams, really, of data. And our speaker today, Dr. Ruchika Goel, is taking advantage of those reams of data and mining those data in big data type of analyses. I'm going to tell you a little bit about her background to give you an idea of how she got to where she is now. She did her MD at the All India Institute of Medical Sciences and a master's subsequently in public health, epidemiology, and biostats. And I guess that really set the stage for where you are now in research. She did that master's at the University of North Carolina, Chapel Hill. And she did a bunch of postdocs afterwards, predominant, I guess, at the New York Blood Center and also at Johns Hopkins. Ruchika is now the an associate professor of Southern Illinois University of Internal Medicine and Pediatrics. She's the associate vice chair of research there, as well as executive medical director of anticoagulation services. She's the medical director of Mississippi Valley Regional Blood Center, and she holds an adjunct appointment at Johns Hopkins Department of Pathology in the Division of Transfusion. So I'm really thrilled that you're able to join us today, even though, again, like we said earlier before everybody joined us, that you're not here to share dinner with us later this evening. So thanks very much, and look forward to hearing what you have to tell us.
Thank you so much for that very kind introduction. It's truly an honor being able to share some of our research work, which really is something I'm presenting on behalf of our entire research group. And I hope the dinner invitation still stays after the talk for a future visit. So I'll be happy to take any questions after at the end. So I will be talking today, sharing some of our journey with dealing with big data applications, specifically in the world of transfusion medicine, and sharing the power of large numbers and collaborative research. Okay. Let's see. This is still working. Okay. Here are my disclosures. So the goal of today's talk, I will try to provide an overview of big data analytics. I'll share examples of a range of applications of big data in furthering some transfusion medicine research questions, and also identify some needs and gaps. I'll identify some possible available as well as easily accessible resources for big data applications. We'll discuss some important limitations of big data research, and I'll finally end with trying to lay out a model for the future, aiming for some precision medicine-based applications derived from big data as the next step. So the term big data, it is really a buzzword across many industries, and especially the tech-driven sectors. And the term is actually not new. As of 2022, it's really 25 years till the term big data was first coined in the sense of computer science-related applications. So what does the term big data mean? In a traditional sense of it, it's really data that is too large to be stored using traditional data storage systems and too large to be analyzed by traditional data processing applications. It's multitude of definitions, but it really could also refer to these extremely large data sets that may be analyzed computationally, really to reveal previously unknown patterns, trends, and associations. When we say big, is there a true definition? Is there a cutoff which defines how big is big? And Really, it's really very relative. I did this search on what is the global pool of data estimated to be, and I came across this term, zettabytes, which I was previously really unaware of. And it's sort of, I think, really to imagine a terminology for 10 to the power 21. Really, I mentioned this just to highlight that as of today, really colossal level of infrastructure is needed, not just to process this data, but really even to primarily store this data. It's immense amount of background logistics that need to be put in place. I would like to share this picture, and when I first saw it, I did not have an idea what it was, and it looked like a scene from like a sci-fi movie. But it's not, because this is a picture of the Google data center warehouse, and which basically is one example of how the record keeping of millions of the web pages is. So today, data in the big sense, before we come to how it's applied to health sciences and specifically transfusion medicine sciences, it is something important to know that, there is a physical component to the this voluminous data when we refer to it as big data. So from big data and its wider application to healthcare, if we think about hematology and transfusion medicine, which is of interest to our audience today, the questions are, is there a need? And I would say yes. Is there a precedent? Is this new, or do we have precedent? And yes, there is enough precedent. And is it being encouraged? Certainly, yes. The most recent example, which I'd like to cite, is from United States with NIH and the NHLBI, the National Heart Lung Blood Institute. For the first time, when they recently held their State of the Science in Transfusion Medicine Symposium, they identified 6 subgroups which were given the responsibility of laying down in the next 5 to 10 years what the research priorities in transfusion medicine were. And previously, this has not been there before, but for the first time, novel and emerging data sciences and computational methods were given an independent subgroup of their own, and to be at the level to be recognized as an NIH priority. I did have the honor with my co-chair, Jensen Holt from Mayo Clinic, to be co-chairing this group, and I'm very thankful. We had several excellent participants from Canada who've been key in building up and supporting a research priority build-up. So what is the role and why is data sciences important to be laid out in the NIH research priorities? And I think for a widely applicable, any blood establishments trying to focus on transfusion medicine research. The reason being that the applications of the state-of-the-art data science techniques such as big data analytics, artificial intelligence, machine learning, multiomics, their application to transfusion medicine and blood banking is still in their relative infancy. They can be key to propose newer associations, which could help make better healthcare decisions. They can help us identify and predict patterns and trends which were previously unknown and inform future studies. And it is still pretty much, especially the novel computational methods, remain an underutilized and rather an esoteric concept. And truly outside of highly data-driven business sectors, there's very little rollout. And it is the time to identify how these techniques can drive innovation in the field. Also, we realized that as we worked through a subgroup, this brought together solutions to a lot of proposed approaches that came from many of the other state of the science working groups. Whenever a research question was put forth as a research priority, there were data science techniques which were applicable. So how this specific working group worked was a combination of either pairing one research gap with multiple data science techniques or identifying one data science technique which could be applicable to a bunch of research questions, really to come together and suggest some proposed deliverables. Looking at some background of what is published out there, I think for the most part, the concept's been mentioned and it has been brought up rather, more as review articles, editorials. There was recently very nice commentary published in Transfusion from Dr. Heddle's group. And I mentioned it, quoted several times during the talk, really of showing how the database-driven research and big data analytic approaches could be helpful in transfusion medicine. I do want to mention quickly this example from the group from the Karolinska Institute in Sweden. This is led by Dr. Gustav Edgren, who is a dear colleague who we are collaborating on several studies now. His group has come together with the ScanDat and the newer version ScanDat2 database, where they're very strategically for almost 50 years now, from 1968 to 2010s and 2020, come together with millions of data points from their blood donors, which has very strategically been linked to their national healthcare database. It's still by maintaining, the privacy and for the donors, for the healthcare records, but it has really allowed over 50 years of longitudinal data and really a vein-to-vein linkage to study a lot of outcomes from these donors for their health follow-up, as well as linking it to the transfusions and studying a lot of outcomes. I think as a very strategic example, how it's been done. This is a list which, again, it's really the reason I put it up here is a list that I prepared with Dr. Hedl as we worked on a clinical transfusion medicine committee report for AABB to identify a list of the national as well as international database resources which are applicable. I specifically wanted to highlight the Trust database and the Ottawa Data Warehouse, which are excellent resources. And again, several resources from United States, Netherlands, the Senquin database, as well as the North American database, the NISQIP, which I will be citing a study today from, which is again for United States as well as North America, with a dedicated pediatric version available as well. So before going on to sharing some examples, this is a diagram I picked from Dr. Hedl's commentary, and I really appreciated how in a very simplistic way they try to highlight the difference between the traditional analytics, where it's a hypothesis-driven research model, and an a priori hypothesis could be the basis of the rest of the study. In contrast, for some of the big data analytic techniques, especially machine learning, deep learning, where it's actually a hypothesis-generating research model, where we may not have a priori hypothesis, and truly your data could be the starting point of the research question. Also, in 2016, when I think I was just really making some of my very initial forays into strategically trying to use some of the available, data mining questions to be answered. I had a chance to interview Dr. Edgren, and he at the time in 2016 was the Jean Jollard Award recipient for big data research in transfusion medicine. And during the interview, like two things that really stuck to me, which I have over the time really tried to apply for any of the studies we take over, that to knowing the limit of your data and not going beyond the scope of what the data can answer is critically important. Big data is very powerful, but there's several important limitations, and not over speaking or going beyond that projections beyond what we are able to say is important. And then secondly, that despite the power of numbers, remembering that the power of expertise and having expert opinion and collaboration with getting, the experience really matters. And that supersedes simply, following what a data churn could tell you. So with that background, I would like to walk through several case study examples. It's going to be pretty rapid swings from one application type to another, as I try to highlight using a range of databases, how we have tried to answer some big data questions. A majority of this research has been done with my group at Johns Hopkins, and Dr. Aaron Tobin is one of my mentors, and Dr. Cassandra Josephson. So a lot of the work has been done with them, and just wanted to make sure I offer credit as I try to show from proof of concept to some of the applications. So my first example is going to be what I'd like to call it as the bird's eye view. And really here, we're trying to see how we can use a publicly available database or a registry to study large-scale trends and patterns to see for transfusions and blood component utilization. Just as a background, I think at least in United States hospitals, I don't know if to the audience today, this is a well-known fact that red cell blood transfusion has for long been the #1 ranked procedure performed in hospitalized patients. And it has been targeted by a joint commission in the Overuse Summit, where they laid out the 5 most commonly overused procedures or interventions, and blood transfusions actually made it to the list in the top 5, along with the other list that you see here. So certainly something that has come in the view with as a lot of patient blood management programs started expanding over the past few decades. So prior to this, we have several studies that showed effectiveness of the patient blood management initiatives at an individual hospital, a hospital system, or a center level. We also have from US the National Blood Collection Utilization Survey data that has shown overall decrease at the blood establishment level, a blood center level, decrease in collections, and overall distribution of blood components. But nationwide trends in what is happening to our hospitalized patients regarding blood component utilization remained less defined and was not approached, which brought us to this study. This was performed in collaboration with New York Blood Center and New York Presbyterian Weill Cornell. And the goal being to identify 20 years of data and looking at trends in blood utilization for various components, and do subgroup analysis by age groups, diagnostic procedural categories, and the hospital teaching status. For this purpose, we have utilized the nationwide inpatient sample, or now renamed as a national inpatient sample. In the United States, the NIS or the NIS is the largest all-payer inpatient discharge database. It has been developed as a federal state industry partnership as part of the Healthcare Cost and Utilization Project, or HCUP. There is now as many as out of 50 states, 48 US states participating, including the District of Columbia, and it spans and collects data from over 5,000 hospitals. And between this, it's projected to cover about 95 to 97% of the US population. It contains about 8 million unweighted records for inpatient visits per year, which projected comes to between 35 to 40 million weighted records. And it is basically a sample of discharge records from all participating hospitals with 20% sampling with the weighted estimates. So for this study, we were, in the initial iteration, we looked at 20-year analysis from 93, over 20 years to 2014. And between this, at any given time, we were analyzing 1 billion hospitalizations. I just wanted to put this graph here just to show that in the dark blue versus the teal blue, how the sampling and the population of NIS really compares very well to the large US population. And it's truly how representative the data is, as you can see individually across different regions, as well as for the entire country. So what do the results show? And as a quick summary, what we were able to show here is that up until 2011, as we can say here, for red cell utilization, there was a steady increase, actually a continuous increase in the percentage of hospitalizations utilizing at least one transfusion. And up until the point in 2011, but for the first time, we observed an inflection point, and there has been a statistically significant continued decline in the hospitalizations reporting blood utilization. And this is only red cells, and we can see here it is a significant trend with about 6.3% overall decrease per year. This one also highlighted that this is pretty much around where the peak of, a lot of the patient blood management initiatives, as well as a lot of the clinical trials showing the restrictive blood transfusions were effective and safe. And so it's really it's taking effect with showing in the inpatient data. Very parallel to that were the trends here for plasma transfusion, where we can still see that there is statistically significant decrease in the utilization. It mirrors the same, except the decline started a little bit earlier. However, the percentage decline is, the most effective for red cells, less for plasma, but still we see it here. In contrast, I think platelet utilization has always been something that has been under-targeted, I believe, for patient blood management initiatives. We have, a lot of problem with the compliance with the guidelines, and still it's one product that tends to be significantly overused. And in accordance, we saw a little bit of more like a plateauing, but it wasn't a significant decrease and a very nominal decrease in platelet utilization. So this is basically the overall summary of the and adjusted trends. And what we could actually see is that if we were to compare for even the last 3 years, 2011 onwards, where if we ranked all the procedures in the United States by in the order for the principal procedure code, you can see total knee replacement being the next one. Actually, by 2014, it had slipped down to number 2 in the rank order. So clearly providing evidence that, red cell transfusions, at least there was some controlled and a more restrictive utilization at many levels. On subgroup analysis, we could see that while these results were applicable across predominantly the adult population, we did see that, stratifying by the teaching status, to no surprise, these were first picked up in the academic and teaching hospitals. In contrary, for the neonatal and pediatric transfusion, really no clear trends were seen. And also in the private for-profit hospital, which probably reflects the reimbursement mechanisms here, we did not see decrease in utilization. And which led us to the conclusion that there is need for more targeted patient blood management interventions, specifically for platelets as products, as blood components, for the pediatric age group, infants, as well as older children, and for private for-profit hospitals. Beyond this view from 20 years data, we just looked at some of the more recent data and to reanalyze. And then here's the view from that. It's a summary view, but what we can see here is that moving on from 2015 as late as 2018, which was at the time of this publication, the most recent year data that was available, we could see continued decline in red cell utilization and platelet plasma transfusion, so much so that from the peak in 2011, where almost 7 to 8% of all hospitalizations across all categories reported a blood transfusion, it's now about 3.75%. So less than half it has come down to. So there has been a steady decrease. We don't know if it is at the nadir yet. It probably will be at some point, but at least till 2018, the trend still showed decreasing utilization. Similarly, for plasma transfusion, it's continued to be down. For platelets, it's continued to really be at the same level. One interesting thing is the cryoprecipitate, which was for the first time this analysis was done, and that is the only blood component for which a statistically significant increase in the utilization was seen. And that does make sense because at least in the United States, nationally, there's been severe cryo shortage in the past few years. It also correlates with two things. There has been increasing recognition of role of hypofibrinogenemia in managing the trauma patients. Increasingly, the hospitals are building cryo as part of their massive transfusion protocols. It has traditionally not been there. And even with the concept of balanced transfusion and the ratios, it's really focused on red cells, plasma, and platelets, and fibrinogen has really been an recognized. And I know there's been some fantastic studies from Canada led by Dr. Jeannie Callum and showing really the role of hypofibrinogenemia and how it can be managed using different products. So this we could show with our data that yes, there is a statistically significant increase in utilization. Another thing is viscoelastic testing has gained a lot of ground, and again, use of global hemostatic assays has shown that unlike the traditional thinking, cryo or a fibrinogen source is important to manage patients with massive bleeding. More recently, the 2020 national data, so this is released, we are in the process of analyzing it, which will kind of give our first look at what happened at a national level in the blood utilization during the pandemic, and also a big picture view of the convalescent plasma use around the country. So that's something in the works going on. A little bit of further detailed look at, looking at this data, analyzing it by age categories, what we could see, it was very interesting trends appeared. We separated it by every 10-year age category. And what it told us is that if you were to look at age-specific trends, it really was limited to age 50 years and above, which is where the most forays in optimizing red cell transfusions was made, and that's where the statistically significant decreases in trends were seen. In contrast, for our pediatric patients specifically, and as you can see for patients 49 and under, no real trends, and mostly they're non-significant, showing that our major decrease in utilization was in our older patients. And this basically has been our most recent report available from United States, showing the blood utilization trends in the inpatient population. Switching gears, I would like to show another case example of how big data analytics could really give us power to study a clinical outfusion related to blood transfusions in an otherwise rare disease. And as a hematologist, this is an interest area of mine, dealing with platelet transfusions in various platelet consumptive and platelet destructive disorders, and see if platelets could be associated with arterial thrombosis. There's typically in cases with TTP and HIT, it is considered, but the evidence has really been anecdotal and at a case report level. So the background being that platelet transfusions are hypothesized to provoke fatal thrombotic events, particularly arterial ones in TTP, thrombotic thrombocytopenic purpura, as well as HIT, heparin-induced thrombocytopenia. In TTP, the principal histological abnormality is proposed to be a platelet microvascular thrombus, and in HIT as well, it is heparin-dependent antiplatelet factor immune complexes, leading to immunological platelet activation, thrombocytopenia, and increased thrombotic risk. In contrast, for this study, we used ITP more as like a control disease where transfused autologous or allogeneic platelets really have shortened survival and unclear benefit, but also not proposed to have any adverse effects, just maybe not help at all. So we queried the NIST database to assess the current platelet transfusion practices in hospitalized patients, how many patients who have this diagnosis are being transfused, and see if we could identify any associations with venous and arterial thrombotic events, and also with in-hospital mortality. So this was 5-year analysis from 2007 to 2011, and where we could identify over this period over 10,000 hospitalizations from the NIST database. I do want to emphasize here that the unit of analysis here is one single hospitalization or a hospital discharge. A limitation of the database is that one patient could have been admitted more than one times, and so each different hospitalization is represented as an independent unit of analysis. So in these patients, in up to 10% of cases in TTP and up to 7% of cases with admissions with HIT as the primary diagnosis, we could identify a platelet transfusion reported. We further could see that the odds of the transfusion were significantly higher in patients who had true clinical grade bleeding. In addition, on looking at the outcomes with thrombosis, we did not see any association with venous thrombosis, but we did see on a risk-adjusted analysis after adjusting for various, other risk factors which could be associated with the relationship, seeing in arterial thrombosis being higher with platelet transfusions, both in TTP and in HIT. In contrary, we did not see that relationship in ITP cases. When we analyze a percentage of in-hospital deaths, we can see that we captured about 9% all-cause mortality in TTP. And this is something that we are still aware that despite plasmapheresis, for the most part, the mortality still remains at 8 to 10%, and about 3% mortality in HIT cases. And again, platelet transfusions were associated with a higher risk-adjusted odds of mortality in both these cases, and not so in ITP. So this study provided the first comprehensive national estimates of what the platelet transfusion practices are in various platelet consumptive disorders like TTP, HIT, and ITP. We could say that the platelets are frequently administered in these platelet consumptive disorders. They are likely administered to the sicker patients, likely those with clinical bleeding, and they may be associated with higher odds of arterial thrombosis, but not venous thrombosis, and higher odds of mortality amongst hospitalized patients. In contrast, in ITP, they were not associated with either improvement in survival or with venous or arterial thrombosis. Moving on, as a takeoff from this study, we wanted to explore, can we apply these findings to see if we could come up with a risk mortality risk prediction score in a rare disease. And as we saw that we had about 8 to 10% death rate despite therapeutic plasma exchange, and could we identify a set of predictors of mortality? So using the NIST database, there were about 700 TTP related deaths, which were identified nationwide over 5 years. This is the largest cohort of TTP-related mortality, with the all-cause mortality being 8.5%. And we came up with, after multivariable regression analysis, in this came up with a scoring schema where allotting based on their respective odds of proposing an adverse outcome, including mortality, various risk factors that were proposed. And I just highlighted here platelet transfusions, again, coming up with a factor in the risk mortality score. But patients who had actually developed arterial thrombosis, bleeding, which is uncommon in TTP per se, but if it does happen, renal failure, again, uncommon because it's primarily something seen in atypical HUS in contrast. But when any of these adverse factors were there, it was associated with higher risk of mortality. And here was the score, which then applied, showing that as the number of variables and the total score, the overall in-person mortality was rising. And also showing the area under the curve for this mortality prediction model that we could get AUC of 78.6% with a very good discrimination in a stepwise regression model. Moving on, this is a different application of big data sciences, where for a disease which is otherwise of public health importance and very widely available, could we see if transfusions are a risk factor? And the question assessed was transfusions, are they associated with thrombosis? So for venous thromboembolism, which is deep venous thrombosis and pulmonary embolism, either or of the two being present, particularly hospital-associated venous thromboembolism, it is a major cause of morbidity and mortality. In United States, it is attributed to contribute to 100,000 to 200,000 deaths annually, which represents 5 to 10% of all in-hospital deaths in the United States. As many as 70% of hospital-acquired VTE cases are actually considered to be preventable, which really brings us to the importance of being able to identify any factor which is increasing the risk of VTE. So how does transfusion play a role in this, if any? If we were to look at our traditional textbook teaching, coagulation thrombosis, it's basically considered to be an interplay of endothelial cells, platelets, and soluble coagulation factors. In an otherwise red blood clot, they are typically just considered to be innocent bystanders, which are passively entrapped in a developing thrombus, which is, as it's, with red blood cells, as they're flowing through the vasculature, they just got passively entrapped, and they really don't have a role to play because the primary players are your platelets, endothelial cells, and the coagulation factors. But there is a growing, molecular as well as clinical evidence supporting that there is an inherent role and various mechanistic pathways really linking red blood cells to actual hemostasis, as well as to the other end of the spectrum, leading to a pathological thrombosis. So with that role and similarly, there's studies coming up suggesting the role not only of the native red cells, but also transfused red cells, more like adding fuel to the fire, and how could they be worsening? For this purpose, we utilized the American College of Surgeons, the National Surgical Quality Improvement Database. This database actually spans participating hospitals from the United States and Canada as well. It is a multi-center prospective registry, which is a rare kind of a registry where data is gathered in a real-time basis, and a patient, once admitted to the hospital, is followed as part of surgical quality improvement project, followed till at least 30 days post-discharge and throughout the entire course of the hospitalization. There are 60 plus children's hospitals participating in this registry as well. And the primary goal of the registry is to evaluate risk-adjusted outcomes of surgical patients, and thus hospital-associated venous thromboembolism is one of the factors that is traced. So for our analysis, we used 2012 to 2014 NISQIP. And we identified patients who had new diagnosis of venous thromboembolism. And these, if they had a chronic DVT, it had to have guaranteed post-operative progression. So these are patients who all underwent a surgical procedure and they were followed for at least 30 days post-procedure, including if there was a discharge. There was a definitive imaging modality confirming the venous thromboembolism, or there was either a direct pathological examination if there was an autopsy case, or these are patients not only beyond the diagnosis, they were only considered true case if they warranted treatment with anticoagulation therapy or placement of a IVC filter. Arterial clots were excluded from this analysis. So what did our data show? So between the given 3 years, we could analyze data for almost 750,000, over 750,000 subjects who were undergoing elective or non-elective surgery. With this, we identified about 0.8% cases of post-operative venous thromboembolism. So that is within 30 days, of which, as we can see here, that's the split between the deep venous thrombosis or a pulmonary embolism, and few cases had both. Looking at our red cell transfusions between these, about 6.3% total transfusions, which again, very much is in sync with a lot of what we would see in the United States literature for the percentage transfusions. And these transfusions were stratified as preoperative transfusions. So about 1% of these cases needed blood transfusions, probably to optimize the hemoglobin before the surgery. And about 5.8% received a transfusion, which was intraoperatively. So from the start of the surgery till 72 hours post-surgery, it was considered to be intra post-operative red cell transfusions. We did a pretty thorough risk adjustment analysis for all the factors listed here, which could be independently associated with an outcome of venous thromboembolism. And after using risk adjustment for these, we could show, and this is really our summary graph from the visual abstract, that there was an independent association of red cell transfusions with both deep venous thrombosis alone, patients who had pulmonary embolism alone, and those who had either DVT or P. In all the cases, red cell transfusions were associated, had an independent association. We further went on to see, was there a dose-response relationship? And we did find a statistically significant, and you can see here risk-adjusted odds ratios continue to increase as the total number of transfusion events for these patients increased. Beyond that, which is basically case example 4, really is to applicability of being able to apply these data analytics for specific subgroup analysis, and does it give us the power to study an outcome in specific populations, and where we did an application to a pediatric age group. As we know, children are not small adults, and neonates or infants are not small children. So really the extrapolations from adult data are neither enough or not accurate. We went on to apply this to the pediatric version of the NSQIP, which is called as the ACS pediatric NSQIP. And again, the background remaining the same, what the data showed us is that for children, this is all children, infants, and within first 4 weeks, the neonates, what the perioperative red cell transfusions were. And as we knew that overall, more in the case of infants as well as the neonates, the total number of transfusions were much higher. And here's the data for preoperative transfusions, as well as very high, almost 14% of the neonates receiving at least one intra-postoperative transfusion for all types of surgery types combined. The number of cases, we looked at about 200,000 total cases across the years studied. In children, as compared to the adults, DVT and PE are much rarer. So even with this group, what I want to highlight here is that we had almost 200,000 cases, which gave us the upper denominator, which gives us the ability to have identify just, a few hundred DVT cases to be able to study this question. Again, the percentage of the VTE is much higher in the neonates, which is well known that this is the highest age group, which is predisposed to, in the children, develop a blood clot. Using our multivariable analysis here, we identified, and this is sort of a heat map for really just trying to show the factors which had the highest odds. And we can see here, for example, central line placement would be one of the major risk factors, how sick the patients were at the baseline, showing their American Society of Anesthesiology illness score, and adjusting for all these factors, still red cell transfusions showed about 1.8 higher odds of post-operative thromboembolism as compared to those who did not receive a transfusion. Likewise, and as in adults, there was a clear dose-response relationship seen where stratifying these transfusions by tertiles of blood transfused, we could see that as the total cc per kilo, which is how the transfusions in children are measured, as the total volume of blood transfused perioperatively increased, there was an independent association with venous thromboembolism. So we concluded that perioperative red cell transfusions, again, I want to emphasize the word association here, not causation. They're associated with 2 to 5 times higher risk-adjusted odds of development of a new VTE. These results do need validation in prospective studies and clinical trials. And if validated, these results underscore the need for more stringent and optimal perioperative blood management practices across all age groups. So in the red cell transfusions are possibly another small piece in the complicated puzzle of coagulation thrombosis, but really, every piece, even if it's adding a small total risk as compared to some of the bigger players, like, for example, having a central line or not, what the underlying severity of illness is, having metastatic cancer or not, but it's still an important additive factor. And in a disease like venous thromboembolism, which is considered polygenic as well as a multifactorial, every factor, especially if it is preventative, is important. For some next steps, I want to highlight this is an ongoing project. It's not near completion yet, but some of the big data initiatives driving precision transfusion medicine-based application. And our goal was, this data was just presented in the Blood 2022 conference. And the goal was to use the REDS3 database, which is now publicly available, to identify various blood donor, blood component, and recipient specific factors and how they tie up together in a vein-to-vein database analysis with venous thromboembolism in transfused patients. So when we talk about transfusions and thrombosis, so really the question comes to what is in an RBC bag, and there is likely a contributory role for any adverse outcome related to transfusion. There's some factors probably inherent to a blood donor, characteristics which could be specific to the blood component, what the modification, what process steps it underwent, the storage, as well as some characteristics of the transfusion recipient, which could, in all additive together, alter the interplay of factors leading to a thrombotic outcome. So as a background with Dr. Nareg Rubrinian, who's one of our collaborators, there's publication showing factors affecting hemoglobin increments in transfusion recipients, showing here what factors which were blood donor related, which showed higher increment, blood component related, which showed lower increment, and as well as in a transfusion recipient. And these included donor age, gender, the type of collections, whether it was whole blood versus apheresis, whether it was irradiated or not, storage duration, what the additive solutions were, as well as the recipient factors, for example, what their baseline hemoglobin was, what their body mass index were, gender, as well as their RHD status. And in another study, independent of that, they have studied various donor genetic polymorphisms, again in a vein-to-vein risk linked analysis using REDS3 database for over 100,000 transfusions, where a combination of each of these factors in showing efficacy, transfusion effectiveness measured as your change in hemoglobin, your delta hemoglobin, delta creatinine, as well as bilirubin, and how the donor genetic polymorphisms in combined to the other factors play a role. which brought us to this work where, as an offshoot of that, we wanted to study various donor factors, some of the same factors as before, also race, ethnicity, smoking status, prior history of pregnancy, the various component modifications, the collection method, leukoreduction, use of additive solutions, gamma irradiation, storage duration, as well as the various recipient factors, how they collectively played a role in serving as covariates for a thrombotic outcome. And these transfusion exposures were calculated time dependently on a day-to-day basis. They're allowing the patients to change the exposure with additional transfusions. So what did I'm just going to present this very as a brief summary, and as again this work is still out ongoing and further analysis is being explored, but putting these covariates for donor, recipient, and the blood component together. In our prelim analysis, so far we've identified that in risk-adjusted analysis for donor, the female sex has shown a very slightly higher hazard ratio of developing a thrombotic outcome. Likewise, for gamma irradiation, storage beyond 5 weeks, use of AS1 storage solution and apheresis derived collections also showed very modest risk hazard ratios. And it is important to realize here that each of these individual factors, the actual effect size is very nominal. The hazard ratios are, and really what this translates into a clinical is under study and needs to be investigated. In contrast, if we look at the recipient characteristics, which were analyzed in the same model, so any of these hazard ratios we are seeing are adjusting for the remaining covariates, we do see, as expected, that at the end, for a person to be developing a clot, predominantly it is the recipient characteristics which is the main determinant. And as we can see that some of the previously known trends emerge, seeing with male gender, obesity, primary diagnosis, for example, severe infection, sepsis, malignancy, especially metastatic malignancy, and cardiovascular risk factors. They play a higher role as being predictors as compared to the much nominal hazard ratios as seen here with the donor and component characteristics. And so the conclusions thus far are that using a vein-to-vein linked database, we could identify several donor, component, and recipient-specific factors associated with venous thromboembolism in transfused hospitalized patients. These dose-dependent associations of individual donor and component factors were very modest relative to those of the specific recipient-specific factors. And we need to identify various mechanistic pathways linking each of these factors, every processing step that was analyzed with the thrombotic outcomes. So what this leads us is, and how is it helpful, is that really identifying every modifiable or a preventable variable which is affecting venous thromboembolism risk, or it could be any other adverse outcome at study, that being our model for study. It's really can be applicable for precision transfusion medicine based approaches. And really, can we come up with an algorithm putting all these factors together? If I were to feed it into my analysis in the future, could I really choose the most optimal blood product, and rather than a random simply a cross-match compatible blood component? Can we go really beyond that, and beyond those being our minimum criteria? Can it truly be, is this unit that goes from this gender donor to this gender, whether it's processed from this with this technique going to this age group, is that a better and has the least risk factor adverse outcome while achieving the highest transfusion efficacy, really taking to precision transfusion medicine? Most recently, in United States, the REDS 4P, which is the fourth study arm for the recipient epidemiology and donor evaluation study, P for pediatric, but it's really with a focus on pediatric. The goal is to optimize the transfusion across the lifespan. That is ongoing, and there are definitely some novel methods as an improvement from REDS 3. There is application, and it's really an honor. I'm helping develop the vein-to-vein database, particularly with the team. We are applying the OMOP common data model which is basically as a big summary. This picture is adapted from the Odyssey website. It allows for the systematic analysis of disparate observational databases and really transforming the data contained within these into a common data model or an OMOP model, as well as having a common representation, terminologies, vocabularies, and coding schemes, and then eventually being able to perform systematic analysis using a library of standard analytical routines once this common data model format is written up. So that's how the REDS4 key database is being developed. And hopefully, as we went through several analyses from REDS3 and identified shortcomings, we can make some improvements in some of the limitations from the prior analyses. I just want to give a quick shout out to the patient blood management data visualizing tool called Sanguine, which has been developed by the group at Utah with Dr. Ryan Metcalf and his team, really showing that beyond the role of a non-static, a live data visualizing tool to be able to do, any in-depth analysis and the power of visualization of the data in real time and how that could be helpful. Finally, these are one of the factors, one of the things we proposed in the state of the science, and I've adapted a slide from our presentation there, the need for deploying, robust technologies applying machine learning and artificial intelligence workflows in blood banking and transfusion medicine. And there is really a need for hospital transfusion clinical services and blood banks to adopt these tools and really to ensure that these tools eventually are generalizable, robust, and scalable. But more importantly, I think for the wider applicability and adaptation, these tools, they have to be made clinical grade, and only then there's going to be wider adoption. It has to be something that we can translate down to the end user, to the clinician who is going to be applying this, or the blood banker in their day-to-day decision making, whether it's inventory management or whether it's adverse outcome assessment for a transfusion. So really, if we can show this generalizability, scalability, and robustness, those will be the hurdles to overcome as we adopt some of the novel techniques. Just showing here that, many of these things, there are articles and publications coming out, some really nice ones from the groups in Canada again, but showing artificial intelligence-based prediction in the ICU. This is, for example, in a patient with GI bleeding management, using a massive transfusion and showing the decision tree algorithm for the application of massive transfusion. This is from the Pittsburgh group. And again, in some I think I would say clinical journals which are not widely read, there is applications for example, showing how you can calculate circulatory blood volume for emergency medical care and how that can guide transfusions. I wanted to give a shout out to this work, which Dr. Nali actually participated in, was a very active participant in our group, and showing the work on demand forecasting to inventory management through an integration of traditional statistical modeling, as well as integrating it with machine learning, and how the results were comparable. So some nice forays being made there. And finally, application and a much wider perspective where we could go on to using social media and using the role of artificial intelligence. And this was work done actually in partnership with Facebook and with University of Maryland, showing how donors could receive real-time notification in case of an emergency to identify where the donations were needed or not an emergency on a day-to-day basis and target them to make it easily, and actually showing effectiveness of the rollout. So really the goal for all the informatics and the digital information being eventually to do service transformation in improving quality outcomes, innovation, efficiency, patient safety, with the ultimate goal of being patient-centeredness. I think I'd just like to take 2 minutes to mention word of caution that for some proponents of big data, they say that it's basically what we know is the tip of the iceberg and the rest is big data. And I truly would say that I beg to differ. There are certainly many pros of big data analysis. It allows us access to a very large number of observations, allowing for rare events to be studied, subgroup analysis to be performed, predictive models to be built, tested, and validated. It can really help inform clinical trials or observational study designs by determining appropriate sampling frames. It can inform future enrollments and timelines, but there's a fine line between informing and misleading, and knowing the limitations of your data, and accordingly knowing the limits of inference and not claiming more than your data is worth. A lot of the conclusions really are hypothesis generating. They need prospective validation in future observational studies or focused clinical trials, and there is a need to validate and follow prospectively. And again, importance of expert input to make is that plausible or not. And this is excellent commentary from showing the statistical caution in big data approaches, where there were 2 back-to-back publications in JAMA Internal Medicine, where completely contrasting result of, based on the statistical technique used, variability in the results for donor factors predicting adverse outcome was seen, and how we could understand that better. That's all. I'd like to thank everyone for the attention, and here's all my collaborators, my mentors, who I'm very thankful to, and happy to take any questions.
Any questions? Maybe from outside? Well, I'll start then. You mentioned something about red blood cell utilization and how it's on the decline, but predominantly not within the for-profit hospitals in the United States.
Mm-hmm.
Their learning curve is obviously bigger. Is that because they're just billing back to the patient or to the insurance companies? Is that the only reason? Is it just a financial basis? Or what did big data tell us about the answer to that question?
So that's a great question. And, to tell you the truth, my answer would be at the best speculative, because I definitely can't claim expertise in this area. But yes, to some degree, the way the billing is designed is there are systems where, for every procedure, every additional intervention, once billed, the reimbursement is there. While in contrast, in some other centers, it's evolving as a package reimbursement. So, this is going to be the amount for an asthma admission at this level until the patient gets transferred to an ICU, where a different billing DRG category comes in, and they're going to be a higher package of reimbursement. So inherently, there's a built-in incentive for the hospital to minimize any lab draws, any interventions, keep the procedures, or the duration of hospitalization. There is an incentive to discharge the patient earlier rather than prolong it. But again, I think it would be hugely speculative at my end to say that was the primary reason. I think one of the reasons is that the larger teaching hospitals, they did see, pickup of the initiatives much sooner, which is again not surprising for the teaching and the academic hospitals to pick it faster. But really, I think beyond that, probably, what the reason says, it seems like that. But I think in the future, as we analyze this in the next decade, it'll be important to see how these trends pan out.
That's an interesting question for sure. And I'm wondering whether in our more socialized way of billing for these products in Canada, that same trend isn't as obvious here. We certainly don't have that same stratification of hospital billing versus billing to Canadian Blood Services. We don't have that same trend. So it's going to be an even harder lesson to learn here, I think.
Mm-hmm.
Another question that I have concerns TTP and ITP and the trigger. Can we learn something about the trigger for those two to mysterious, really mysterious diseases from big data? Is it viral? Is what is inducing it? Can we learn something from those huge database sets that you've been mining?
So the question is the trigger for transfusion, for like a platelet transfusion?
Well, no, I'm talking about the molecular basis of inducing the disease itself, not the trigger for transfusion.
Got it. That's a good question. I think it would really depend on the granularity that's offered in the database queried. Just to give an example, I talked about the manuscript from Blood in 2019, where with the REDS3 database, as far as what the REDS3 database offered, in the initial version, we did not have any of the genetic polymorphism data, and the granularity was to a very different level. But then, as a subsequent version of this study, when funding was obtained for a specific subgroup with this specific question in mind, we could actually get to a much more detailed, some of the data was just retrospective, going through the charts and pulling out, for example, details of the fluids, the medications. So I think it's completely variable, what the limits are. And some of the, every time I feel like I've written one of these manuscripts, it has gotten over the years also, almost with, 7 to 8+ years of dealing with this. I see that in some of the newer iterations where it's coming out, the coding is becoming more specific, but there's huge limitation, and that's very, very database specific. But the newer thing is, for example, with REDS4P, what we are trying to do is to overcome these limitations by identifying what we are calling like a DAR request or data access request, and going back to NIH with a very specific proposed funding, that it's not something that could have been done in these 100,000 data points, but can we focus on these specific 8 or 10,000 hospitalizations and address this specific question? I think specific to TTP and HIT, to my knowledge, none of that thing is available, that level of granularity to be able to study that.
Not yet. Thank you very much. Any questions from the audience? Oh, thank you. Nargis has said, thanks so much for the excellent talk. Could you please comment on how you'd evaluate if you want to pool data from more centers or hospitals to have an even bigger data, or choose having smaller data but include only those hospitals with more similar practices, methods, or policies?
Right. So that's an excellent question. I think now that I feel that in the transfusion medicine and blood banking world, there's definitely in the United States being more recognition, in the past decade of really seeing how any of these studies can be better planned. Even as I see from going from REDS3 to REDS4P version, we are doing very similar, both the mechanisms being followed, that, for example, if there are hospitals that have similar practices, if we pull it together, that gives us a wider, denominator to be able to study, and a more homogeneous denominator. In contrast, sometimes having hospitals which have really varying practices, methods, and policies is equally important to be able to study, how that particular thing is affecting the outcome. The nice thing about some of the large REDS4P is not nationally representative. It is geographically for diverse areas representing, for the most part, different regions in the United States, but they don't have a mechanism by which we could do like survey methodology, or to generate nationally representative estimates, just like I showed with NIS, which actually samples 20% hospitalizations, but there's a very nice validated weighting mechanism built in to generate from 8 million hospitalizations projecting to 35 to 40 million per year. But it does give us an option that, we could, for example, do a subgroup analysis of just academic hospitals. We could do a state level analysis and and just see and compare and contrast. Or we could do comparisons between, hospitals that have primarily one different type of funding, or patients that come from a primary, private insurance base versus Medicare versus Medicaid, and compare and contrast the outcomes. So I think both the options mentioned here can be applicable in a different setting and serve a unique purpose.
Thank you very much. And with no further questions, I thank you in a big scale. Thank you very much.
Thank you. Thanks for inviting me.